Good evening, everyone. My name is Shalini Sood. I am one of the glaucoma specialists at Coli Institute at the Cleveland Clinic. And this evening, we're going to have a discussion about co-managing glaucoma with our optometry partners and how we utilize Zeiss Glaucoma Workplace as well. I've been at the Coli for a little over 14 years, and up until 2 years ago, I pretty much have been practicing on my own with no co-management with optometry. But I've reached the point where my practice is very mature. I have many patients who've been seeing me for that entire time. And as we know, the frequency of number of times patients need to come back to see us, it's 2 to 4 times a year. And this puts a very heavy load on our clinics. So this has been a challenge. And so finally, about a little less than 2 years ago, I decided to pivot and integrate an optometrist to my practice. And this has been really incredible for everyone, myself, my patients. And so tonight, we just wanted to discuss opportunities for that kind of collaboration and some of my experience, as well as Dr. Marrelli's experience being on the other side of optometry. And so I just wanted to highlight some areas that you may find is key for collaboration. Those may include post-operative follow-up, especially our glaucoma patients who tend to see us multiple times in that post-operative period. I mentioned refractions, and I found this, I didn't anticipate this, but especially for many of my cataract patients who I may be kind of considering monovision or specialty lenses, doing a contact lens trial, I no longer have to think about that. I can have my optometrist working with me work on that for my patients. Of course, referrals for cataract surgery and glaucoma surgeries. Referrals for lasers. I've found that it's been fantastic in streamlining those patients who maybe get initial evaluation and would be excellent candidates for SLT. And they end up just going straight to my laser clinic. And I can, again, take care of them in a very efficient way. Also, LPIs and, of course, YAG lasers for those post-cataract patients. Because, again, my practice is very mature, there's not, we have some slots for new patients, but it's not infrequent where someone in our Coli Institute, needs an urgent glaucoma evaluation. And it's been really tremendously very helpful to have the optometrist who works with me help to triage some of those glaucoma evaluations on a more urgent basis. And because we work in tandem together in clinic, she tends to come over and we can work together and figure out the next, step for our patients. And we'll also talk about, based on the severity of the glaucoma, when it's appropriate for those patients to stay with optometry versus, come to ophthalmology. And then follow up for our stable post-cataract patients, follow up of the low-risk glaucoma, ocular hypertension patients that we're going to be discussing that oftentimes don't need to stay with the ophthalmology practice and can very effectively and safely stay with our optometry partners. So we're going to also touch on models of collaboration. In my particular practice, it's worked that the optometrist is integrated fully into my practice, and Dr. Marrelli will speak towards how she and her ophthalmology partners work together in ways where maybe they might be in different sites and then collaborate on an occasional basis. But in my particular practice, the optometrist works in tandem, like I said, with me in the clinic. And when I'm not in clinic, I'm in the operating room, she's still seeing patients on her own. And it works really well for me in particular. But we've expanded this within our institute, and some of the other ophthalmologists have now integrated optometrists where maybe they are working with several different ophthalmologists. And so they've created a program where they're training the optometrists for like a 6-month period to work with the different surgeons. And this really gives a time, especially for some optometrists who may be just coming right out of residency, to get a better understanding of what the glaucoma specialty requires from this collaboration. So I think it's been really nice for building confidence for both sides of having like this period of learning, shadowing. They're in the clinic working with the ophthalmologist, and then also spending time in the operating room to really see how these different surgeries work and and have a better understanding of, the postoperative care when you see exactly how the surgery is done. I think I'm going to pass this on to Dr. Marrelli to just talk a little bit about how you integrate ophthalmology in your practice.
Thank you. So I'm in a university practice. It's all optometry, and I'm in our medical eye service. And so we see patients who are anywhere along the glaucoma continuum, suspects, ocular hypertension, early, moderate, and even late stage glaucoma patients. And the primary way that I interact with our ophthalmology glaucoma specialist is he comes to our clinic once a month. We sort of line up all of our lasers, and he does all of our SLTs and iridotomies on that morning. And then once he's done with the lasers, he comes over to the clinic side and consults with us on some of our more complex patients, maybe patients that we think are ready for surgery, or sometimes we just want another opinion about if this is the right, the best treatment for them. And, are they stable enough? Does he want to start seeing them, or kind of just get his opinion about it? And so we line up those patients who we want some type of touch point with him. At this point, I've been working with him for more than 20 years, maybe 25 years. And so it sounds like similar to your practice. I can say, this is a patient that has primary open-angle glaucoma. I think they need SLT. And he says, okay. And he just, will go ahead and do that SLT or iridotomies, that sort of thing. So it actually works really well for us. Of course, when the patient needs glaucoma surgery, then I refer them out to his practice, and he takes care of them in the sort of, I would say 2 month or 2 month postoperative period, just because we're in really different locations. And so if I were to see the patients in the immediate postoperative period and they had a complication that really needed him, it becomes a little bit tricky. So in my situation, it's different than yours, where the optometrist is right there in the same area.
I don't know. Actually, I wanted to speak to the follow-up based on the state laws too, because I didn't realize this. In Ohio, we don't have any specific, this is the frequency where a patient needs to see an ophthalmologist. It is just assumed, whatever the best care any eye provider can provide. So I think it's a little different at Texas.
It is. So every state is different, actually, because optometry is a legislated profession. So every state has their own laws, and some of them are quite prescriptive and some of them are more general. In Texas, I can treat any glaucoma, except I cannot independently manage advanced glaucoma. And so once a patient hits that advanced stage, and that's according to Medicare guidelines, then I have to have consultation with the ophthalmologist. But that's certainly a more restrictive law than a lot of states have.
But you can still co-manage. So
Yes.
They have to see the ophthalmologist, but then they can come back to you for interval.
That's right. And that part is not prescriptive. It's sort of between the optometrist and the ophthalmologist.
Okay, well, I think we're going to get started on some cases and kind of get an idea of how each of us, again, integrate this collaboration.
So I have a case I'd like to share. This is sort of a very typical case for me. I think in your glaucoma specialty practice, you probably don't see a lot of initial, is this glaucoma or is this not glaucoma? But I see this a lot, right? I get a lot of referrals from our primary care vision center. This is Victor, a 61-year-old Hispanic man who was referred to me for a glaucoma evaluation because of big CDs. That's a very common thing that I get in my clinic. His ocular history was unremarkable. His medical history wasn't really contributory, and there was no glaucoma in his family. His vision was good, 20/20. All the entrance testing was normal. His slit lamp was normal with no signs of secondary causes of glaucoma. Gonioscopy was open, and his intraocular pressure was 22 and 19 the first time I saw him, with slightly thin pachymetry. These are Victor's optic nerves, and I will draw your attention to this little disc hemorrhage right here. Yes, he has large CD ratios, but he also has a really large optic nerve. And so, the question, is this just a large cup and a large nerve, is kind of answered when we see that small disc hemorrhage there. These are his visual fields. So we see a pretty normal visual field in the left eye, and then an inferior nasal step. This needs to be repeated, but certainly is suspicious with that superior disc hemorrhage in the right eye. And here are his OCTs. His RNFL OCT, I think the first thing that you notice is that these are gigantic optic nerves, right? So all of our numbers here are gray because his optic nerve is so big it falls out of that reference database. But the other thing that you notice is that everything on his OCT is green or even so thick that he's white. So he has a lot of nerve fiber layer, and I think at first glance you might think that this looks like a normal nerve fiber layer. And his ganglion cell GCIPL scan looks very good. One of the things I really love to do, though, in Forum and in Glaucoma Workplace is to do a structure function printout or map that we can import into the patient's chart because it gives everything that you are looking at in terms of your structure. So I've got my RNFL OCT, my ganglion cell OCT. I've got this is a slightly different time point, photographs of his optic nerves, and then his visual field. And so there are really a couple of reasons why I chose this case. And one of the reasons is that we're all busy. We're looking at OCTs very quickly, and there's a real tendency to rely on those reds, yellows, and greens. And if we look at his OCT from a red, yellow, and green perspective, he's totally in the green. But it is very clear that he has glaucoma. And we can see that here in the superimposed right eye, left eye T-SNP curve. We see that he has a nerve fiber layer defect visible on his optic nerve photograph, and it matches perfectly with his inferior nasal step. And so one reason I chose to present this case is just a kind of a reminder. I remind myself, I remind my students to not rely on reds, yellows, and greens as your sole measure of whether an OCT is normal. But the other reason that I brought up this case is because it's an initial treatment decision. And so I'm very happy taking this patient, beginning his treatment with meds or referring for SLT. But I wanted to ask you if you have, fully gone to SLT as first-line therapy, if you have, or if you haven't, and do you offer it or do you recommend it based on the results of the LIGHT trial? Is this a patient that should just start on medication? What kinds of things play into your decision on first-line therapy?
With the LIGHT trial, it's really helped to support our discussions when we're bringing up options as far as SLT. And I am offering it as a first-line treatment. And for most patients, it makes the most sense to at least try it. It's a very safe and effective procedure. And I think as far as when you have that discussion in a way that really explains, the data behind it, and that we feel really confident in the results and safe and offering this, I think it kind of takes away some of the fear that patients have about laser intervention to their eyes. And then you offer the alternative of you're going to otherwise, potentially be on drops for your lifetime.
Right.
And the optometrist who works with me also feels comfortable having this discussion. So as I'd mentioned earlier, there is now this more of a streamline of, okay, she sees a patient, she has the discussion, and then they end up, with me for a very straightforward laser clinic. And then depending on the severity, if they end up staying with me or they go back to her for follow-up and management from there. So it's worked out quite nicely.
And I think, one of the things I showed this before, the structure function map, but this is a really nice way to communicate, between providers. So rather than send over 8 pages of, fields and OCTs and that sort of thing, this one screenshot can really show. Now, this is an initial diagnosis, so it's not progression analysis. But this is a great way to say, like, look, this is what the patient looks like, and I'm recommending SLT, or the patient is opting for SLT. In my clinic right now, what I would do is simply schedule a patient into the laser clinic that we have, and he would get the laser. But I also still have a lot of patients who really want to at least think they want to go on medication first. And so, certainly that can happen without me involving the ophthalmologist at all.
Yeah, I think that's a challenge. I think to pitch laser now is the probably superior option. I think I'm in the same boat, right? I sort of sell them, and I'll even try to recommend laser, and a lot of people are still like, I think I want the drops, because I think being shot in the eye with a laser sounds concerning. So there's people use different terms. They'll describe it as like, therapeutic light or something like that, right? That's a little bit less less gruesome sounding. But I think it's worth absolutely trying to pitch that as a solution that makes more sense for most people is laser.
So one particular patient that I wanted to mention was a 68-year-old African American female. She presented for glaucoma evaluation with my optometry colleague. She had been started on latanoprost 2 months prior by another ophthalmologist and really hadn't moved the needle on the pressure. The patient also complained of some hyperemia, no previous lasers or ocular surgeries. So today, or on presentation with the latanoprost, her pressure was 20 and 16. She did have a family history of glaucoma. Her best corrected vision was 20/40 and 20/25. We did do a glare test that day, and the vision was 20/70 and 20/40. You could see that she had a myopic correction. And so the optometrist who works with me, she changed the latanoprost to Cosopt because, again, she was complaining of some symptoms. She asked the patient to follow up for a repeat visual field and possible cataract evaluation with MIGS. So this was the OCT, and you can see some RNFL, thinning in the right eye. The left eye has some relative superior thinning, but overall, the health of the optic nerve was good on clinical exam. And we could see that she had an initial visual field that did suggest some arcuate defects. And then on the repeat visual field, there was some improvement, but it did show defects in both eyes. And I just wanted to point out that, one of the nice things about being in a practice together where we have glaucoma workplace is that we can see the same data at the same time. So we have the OCT very easily, and I do really appreciate the particular visual field overview that we have available to us, just because it pulls up all the visual fields at the same time very easily, and we can easily scan. And so again, when she comes over to see me about a patient, it's a very quick, let's review all the tests here. And it's being much more efficient when we're kind of reviewing our records. So on the follow-up for when she switched to Cosopt, her pressure had decreased from that 20 and 16 to about 15. At this time, my optometrist thought it would be, we needed to have the pressure slightly lower, and she offered the patient the option of SLT, and also possibly for the option of maybe getting off of the drop if we got a sufficient response. Or they go with MIGS, because as we had done the glare test, she did qualify, and she did say that she was having some more difficulty with her daily functions. She was interested in trying the contact lens for the monovision. So this was like a perfect situation where, maybe I would have been spending a lot more chair time trying to figure out what are the patient's, expectations, and am I going to reach them with her? But instead, my optometrist was able to spend that chair time in the most appropriate way too. Then she could provide the trial lens. So the patient came back, as if you remember, she was a -3.5. She came back, returned to the optometrist, and the same day that I was there as well in the clinic. And she, reported she didn't like the monovision. She just wanted to be plano for both eyes distance. So great, we're on the same page. And then we had a discussion that we should go ahead and address the glaucoma at the same time. And again, my optometrist was able to have a lot of that discussion already, and she's built some rapport with that patient. And we decided we were going to do a canaloplasty plus goniotomy in both eyes. And the way that it works in, again, the workflow for my clinic is that I've got my separate clinic, the usual like 40, 45 patients. She's got her clinic, about 20 patients. But then if there's any overlap where I need to see them, then she'll bring the patient over to me. I'll meet them, or I'll come to her clinic and we'll have a discussion of this is what it is, what we're planning to do. And then we can go ahead and I can do my exam and comfortably sign them up for surgery. So post-operatively, it was, again, a back and forth between myself and my optometrist. They were seen post-op day 1 and post-op week 1 with the optometrist. And post-op 1 month is when they typically will come back to see me. And she was best corrected, without any correction, rather, 20/20. Pressure was 11. She was still on the Cosopt at that point, and she was going to do over-the-counter readers. Now, and for follow-up, I decided she's stable. This is a great case of a patient who has now been surgically managed and now can have safely be and effectively managed medically with the optometrist. So I scheduled this patient for 3 months for a repeat visual field after the cataract surgery, and then to decide about if we need to continue the COSOPT or not. And I will, defer to my colleague at that point.
Great, Sean, maybe you can back up to the OCT for me once. I just wanted to point out something there that might be of interest to folks to look at. So this is one of these folks. This person's a little bit myopic, remember? So if you look at the peaks of the RNFL distribution peripapillary scan, they're kind of in the middle of that plot. You'll see those peaks are sort of shifted nasally a little bit. So sometimes you'll get these weird redistributions of neurofibrillary depending on refractive error or other things. And so it's worth paying attention to that to see if some of that is real red disease or actual change. Obviously, the whole thing looks thin, even up top in the top left up there.
Right.
But you got to be careful you don't get fooled sometimes by sort of errant scans. But this person obviously has something going on, particularly in the right eye.
Yeah, no, I agreed. Absolutely. Now, obviously, this patient needs a repeat OCT in the future. The clinical exam definitely was consistent with the asymmetry and did suggest, some visual field defects, and that's why we repeated it again. But yeah, no, I agree that is something to be very cognizant of, that nasal shift as well.
And then how do you think, Shalini, about when you're thinking like these MIGS kind of procedures, how do you think about different options for folks? Like, do you have a strategy in mind when you're seeing somebody?
Right. Again, that's like a moving target, because every 6 months we have something new to offer to our patients, which is, a wonderful problem to have. And I think, again, the paradigm continues to shift. I will say that as a few years ago, I was doing a lot more Zen, and now I've shifted to more, canaloplasty. I personally am using more of the Omni, with their higher dosage of Helon available, but and also now there's a superciliary, device as well, the Alaflow, the graft. So pretty much every patient that I'm taking in the operating room, they're on a medication. I'm treating them for some kind of minimally invasive glaucoma surgery. If it's mild, most likely they're getting a canaloplasty. I will do a goniotomy at this point if it's just like ocular hypertension. And then if it's getting more to like the moderate severe, then I'm thinking, canaloplasty, some level of goniotomy. And now in some cases, the superciliary graft versus maybe a combination of them. And I'm still, very much a proponent of trabs. So I've gone back to doing trabs. They work. And, when they're severe, that's what's going to get you to that less than 10. So I don't know. And then, of course, our tubes, there's always options. But what's your approach, Michael?
Yeah, I think so. If I'm going to kick someone to the OR for cataract plus something, I've settled on the Hydrus as my default procedure. I think that one's got the best evidence for it. It's sort of that versus iStent, that was better. It's the one procedure we've got in this category that's been shown to preserve visual field versus cataract alone. So I think that one has stronger evidence for me. So I like that one as my phaco, angle procedure thing for now. But I agree that's also target pressure dependent, right? So that does not get your pressure as low as it might need to be. So if you need low pressures, then I agree. I still will break out the old phaco trabeculectomy, because I think that's much more likely to get your pressure down in the low teens
Right.
for anybody who's got severe disease. I think that's important to not, just because you can occasionally get low pressures with MIGS, I think you got to be careful you don't fall in the trap of assuming everyone's going to get low pressures with MIGS.
Oh, right. No, absolutely. I mean, and this is like to our point about the collaboration. I think I've been feeling more comfortable doing more trabs because I have my partner to
Right.
help, just check the pressure, right? Sometimes they just need a little more hand holding. There have been occasions where they have, of course, choroidals, and it's not that I have to see them every time. They just need to be checked in on to make sure there's nothing dangerous going on. That's definitely made my job as a surgeon much easier, knowing that I've got a partner that I can trust that can follow them post-operatively with me and know, a red flag when they need to come see me and I need to take care of them. So it does give me that luxury.
I think that's kind of what you were talking about before with some of the other surgeons in your practice who kind of spend some time with the optometrists and kind of trained them in the things that they want to be looked at. Everybody's going to have a little different procedure. Everybody's going to have a little different threshold for when they want to be contacted about a potential complication. And I think it's probably much easier for you to release that early trab to the optometrist when she's in your office versus if she's out in the community. And it's not that an optometrist out in the community can't do that, but if there is one of those more urgent complications, the way you have it set up right now, you're right there. You can come over and see that patient and take care of the problem right then.
Right. Yeah, and I think also, the optometrist that does decide to collaborate with the ophthalmologist, as we're talking about MIGS, I mean, they do have to feel that comfort level of dealing with high FEMAs, or the pressure spike. So that training is really, really helpful.
Okay, let's move on to your next case, Shalini. I think we're
Okay.
keep going.
Sounds good. So this is let me just a second. 70-year-old white female who had been referred for, basically she was having some blurry vision. And she had cataract surgery with another comprehensive ophthalmologist and complaining of anisoconia, had multiple remake of her glasses, had been giving another glasses prescription, but was really still struggling on reading on follow-up. Her pressures, so she had been referred to my optometry colleague, who sometimes also will help with some of the other ophthalmologists, within the practice or outside practice. So pressures of 26 and 24. She had a history of LASIK for distance. Right eye was her distance eye, and left eye was her near eye, rather. And she had also a history of retinal tears, and then, of course, the cataract surgery that had been done just 6 months prior. So she had been on timolol, BID in both eyes for 10 years for mild glaucoma, and her pressure in the past had been in the range of the mid-teens. So my optometry partner tried to remake the glasses, but then on exam with this pressure of 26 and 24, of course, red flag, we've got to follow this up and see what's going on with her glaucoma. So she had her follow up with her for more of a thorough glaucoma evaluation, not just this glasses check. Let's see. So this was her OCT over the last basically 4 years, and I will say the one highlighted in blue was done with my optometrist on follow-up, and her pachymetry was thin, not unexpectedly, 495 to 505. She had been changed to COSOPT, and so now her pressure was 16 and 20. So again, this gives us glaucoma workplace, gives us the ability to see over time that, what is happening with our RNFL. And you can see that the average RNFL, we expect about a 1 to 1.5 micron decline per year is going to be more than expected. So if we get about a half per year, that is expected. But if it goes to 1 to 1.5, then we should be a bit more concerned. And in this particular patient, you can see that the right eye overall looks like it's holding. And especially in like the last couple of years, we could be questioning, maybe there's when I would say this is before the cataract surgery. So on the left eye, we see that there has been, again, overall, the average RNFL was holding, and then the most recent one that was done in 2023 before the cataract surgery did show a little bit higher decrease from the prior year. And that could have been a red flag that, maybe we should be thinking about what's going on with the glaucoma. Again, this most recent one was the highlighted one was done post-cataract surgery with my optometrist. And you can see that rate of change is higher than that 1 to 1.5 microns per year, especially when we consider over the last, there was a pause between that 2023 to 2025, but this could have been a red flag. And so this is, again, using the glaucoma workplace, you can kind of see this, or even on your progression analysis, that's a great way to get just a snapshot of what is happening over time. And of course, with glaucoma, the more data we have, the more likely we can feel confident about what these results are showing us. So as far as the visual field, you can see that previous visual field showed some inferior arcuate defect in the right eye, and it looked normal. Maybe there's some borderline changes. And again, this is before cataract surgery. So this depressed mean deviation could be just a reflection of the cataract, is possibly what they could have been thinking. And then the left eye, the previous one done in 2020, basically looked normal. And then prior to cataract surgery, we do see this arcuate defect. So I'm going to just kind of highlight that, I think in our very busy practices, sometimes we get very reliant on our OCT. And so even though we were doing OCTs in, 21, 22, 23, sometimes, doing the visual field, we're thinking, okay, it's looking pretty stable, not, and the pressures are fine, things are pretty stable. But I do want to stress that it's so important that we're always doing the visual fields as well, because you can definitely pick up functional changes, even maybe sometimes when the structural changes look like they're stable, or if we're getting closer to a floor effect where it's hard to see some subtle changes in on the testing, diagnostic testing. So unfortunately, we did repeat the visual field, and the optometrist repeated the visual field, and it did confirm that arcuate defect inferiorly, and now is also suggesting maybe there's some progression in the superior arcuate as well. So the patient was changed to COSOPT and scheduled follow-up with myself, the ophthalmologist. And so this is kind of where we're talking about now. We're getting to more advanced disease, even though the pressure is now very well controlled, 10 and 11. It's helpful to also have another evaluation with an ophthalmologist, just so that we have, confirmation and another discussion with the patient. And I'm just showing again the visual fields changes and following it over time. And that was the right eye. And then you can see the left eye definitely has had a significant decline in the mean deviation. So a couple points. One, always do visual fields in conjunction with your OCTs. We can't only rely on OCTs. And two, I do make it a practice, especially after cataract surgery. Again, sometimes I get so caught up in correcting the vision and the cataract and the postoperative that the glaucoma gets on the back burner. And if we kind of make it a practice to always, once they've finished their cataract surgery, maybe the next follow-up should be a visual field. And that's kind of what we've incorporated into our practice is, 3 months or 2 months from, depending on the severity of the glaucoma, after the cataract surgery, always the next one should be, let's get a follow-up visual field following, their surgery. So I just wanted to highlight, from my standpoint, I think the teamwork and collaboration really leads to better access that I found in my practice, and it allows both of us to work to practice at the top of our license. It's really important. As we know, the aging population is anticipated to be 4.5 million glaucoma patients by 2030, and we only have a limited number of glaucoma specialists. So, together we can really help to manage postoperative care and triaging, initial evaluation, and co-managing, and really providing quality care for our patients.
Okay, the last case that I wanted to share is another initial diagnosis, but a little different than the one that I talked about before. This is a 25-year-old white man who was in our contact lens clinic. He was a university student. He just came in to get some new contact lenses, a high myope, 7.5 diopters of myopia, wearing daily wear, monthly replacement soft contact lenses. This is just a typical patient in our contact lens service. He was healthy, unremarkable ocular history besides his myopia. No family history of glaucoma. His vision with his contact lenses was 20/20. All of his preliminary tests were normal. Slit lamp, I'll show you some pictures in just a second. His pressure was a surprise, 21 in the right eye and 38 in the left eye. Gonioscopy showed a really deep angle, ciliary body band visible with a uniform, heavily pigmented trabecular meshwork. So you can anticipate where we're going here. This is just a slit lamp image, and it's a little hard to appreciate, but he had these sort of circumferential kind of furrows where it just looked like he had taken a pepper shaker and just shaken pepper into these little furrows in his iris. I'm actually really proud of these photos. I'm a terrible photographer, but I got these radial iris transillumination defect photos in both eyes. And then not very proud of these photos that I took of his gonioscopy showing very darkly pigmented trabecular meshwork, and then this little band of pigment on the posterior surface of his lens. So obviously he has pigment dispersion syndrome. He has really elevated pressure in the left eye, mildly elevated pressure in the right. These are his optic nerves. These are a little blurry, but you can see these very kind of small optic nerves compared to those really big nerves that we saw in the previous patient with an obvious superior rim notch in the left eye. When we look at the red-free photos, although he has a really pale fundus, he's a very lightly pigmented guy. You can see all these choroidal vessels, but you can clearly see that there's essentially no nerve fiber layer superiorly in that left eye, maybe a little early wedge inferiorly in the left eye, and maybe a little hint of a nerve fiber layer defect, although I didn't appreciate this clinically. When we look at his visual fields, you know, my heart just kind of sinks. This is a very young patient with a really significant inferior arcuate defect in that left eye that correlates really perfectly with the loss of nerve fiber layer superiorly. So again, we have all gray, and in this case, it's because those nerves are really tiny. We see, you know, this obvious loss of nerve fiber layer in the left eye superiorly, and you see a little bit of that temporal shift of peaks that's really common with myopes. If we come over to his ganglion cell map in the right eye, we see that, I call it like a donut sign. I don't know what it's really called, but it's that kind of outer thinning in the GCIPL map that's really characteristic of myopia, not really characteristic of glaucoma at all. In the left eye, though, I mean, there's really dramatic loss of ganglion cell, and up in the thickness map, you can see that temporal raphe sign, but in reality, he's lost a lot of ganglion cell, really all around in the macula. And so the things that I think about this, and the reason I brought this case is because, you know, I think that this patient is so young and has such a significant case of glaucoma. I mean, this is not early glaucoma, that I really wonder if surgery is kind of inevitable. And certainly I can initiate therapy. We could go with laser, we could go with topical medications, but I think that it is very likely that this patient will need surgery in his lifetime. And if he does, should I be referring this patient to the surgeon early, not necessarily for early surgery, but for at least an early introduction to the idea of surgery? And so I'd really like to get your thoughts about that.
So I was going to go back to that myopia. Yeah, I think of it as more of like a compact. I kind of refer to it as compact on that GCIPL because you do definitely see that with some of the higher myopes. And so it doesn't necessarily mean, I guess, in this eye, you know, that there's obviously as much disease as it is in the left eye. And I think this would be a case that I would likely see pretty soon after the optometrist sees the patient, probably within, you know, a couple months, depending on where, you know, starting treatment. I can't recall now if you had started treatment. I remember his pressure being really high, but
yeah, we started treatment on him, but I still think that, you know, the likelihood that we're going to be able to really manage that very high pressure
right.
with a tolerable amount of topical therapy is probably not really very realistic.
Yeah, no, I think probably what would happen was that you start the drops and then the patient would be referred to me within probably a few weeks to make sure that pressure is trending down for possible SLT. And then oftentimes on our challenging patients like this, we'll be coordinating, you know, the care as far as 2 months back to her and then schedule at the same time, maybe a 4-month pressure check visual field with myself. So we'll kind of maybe do a couple visits in anticipation that this patient is going to be really followed very closely. And it's very much like a tag team effort. And basically with that understanding that we work in conjunction together. And I think that Actually, for my patients too, it works out nicely because they then develop a rapport with both of us. And so when this patient may get to surgery at some point, then, I've already established my rapport with them as a surgeon, but she's already established too that, when the postoperative they've been stabilized, they can feel comfortable that they're going to be following up with her as well. So
yeah, and that's exactly what we did. We started therapy, brought him into the laser clinic, kind of got that consultation, who's going to manage this patient most of the time? How often is the glaucoma specialist going to see the patient? And it actually it works out really well for us to have visits where we do some of the testing. So all that's been done on the visit that he comes in and sees the specialist. And, we're making interim decisions, but there is really a collaborative effort in taking care of this patient, because I think it's very possible that he's going to need surgery.
Yeah, I think I agree with that. He's very young, and actually, even that right eye, that's very small disc. That amount of cup is concerning, right? So there's probably some degree of damage here in both eyes.
Of course.
And I think I guess talk about laser in this patient. I think it depends how much pigment we're talking about. That can be an impediment, right? If you're trying to laser through that giant pile of pigment, you may make things worse. Those can cause really high pressure spikes in some of these folks. You got to be careful. I think with laser in these really kind of lots of pigment dispersed kind of folks.
Or
The other thing is just
potentially
trying to figure out where they are in the sorry.
or potentially treat like half if you feel.
Yeah, right.
And I
So
think,
certainly want to go
that's
less
what we
treatment, right,
did
to
actually,
start.
is we treated half. Yeah.
Yeah. And the other thing for him is that there are sort of phases to this condition, right? Once you've dispersed all your pigment, you're sort of over the peak, right? And so maybe if he's controlled after that, and then he's sort of just, quote, the burned out pigment dispersion, he's a little bit young, so maybe he's not there yet, but that is a phase that seems to occur with some of these folks. So you can sort of monitor them there. But I agree that the risk of glaucoma loss is very high in this condition, so you got to be very careful with it.
Yeah, and I think with all that pigment going through the TM, you just wonder, is it really going to burn out, or is the TM going to sustain damage? And you could get all the pigment out or not have additional pigment liberated, but that TM is damaged and you may not go back to a normal pressure. So, it's a patient that needs to be followed very closely. It really worries me that he has that much vision loss at his age.
Well, these secondary glaucoma patients do tend to respond quite nicely to like a gap procedure or canaloplasty. So I think he would be a really, a good candidate for something like that when he gets to that point.
Right.
Yeah, because obviously the fundamental dysfunction here is meshwork is plugged up with stuff, right? So getting rid of the meshwork, opening that up it makes a lot of physiologic sense, I think, right, as a choice. Great, no, great case, Danica. Thanks very much.
Sure.
Yeah.